It's really critically important to be able to integrate biomarkers and molecular assays into the care of the breast cancer patient. First of all, the pathology tissues are examined in a traditional manner, and the tumors are graded. They are staged according to margin status, actual tumor grade, lymph node status, and so forth. And all of this is integrated very closely with hormone receptors, including estrogen receptor and progesterone receptor. Some institutions, including ours, use proliferation index, such as the Ki-67 proliferation index, which we integrate, and also, of course, HER2 status. We do semi-quantitation for these hormone receptors, as well as for the Ki-67 proliferation index, and we do all of these according to the ASCO-CAP guidelines. I can't emphasize enough how important it is for laboratories to follow the ASCO-CAP guidelines for these biomarkers, because the evidence that has been weighed by these committees clearly indicate the most robust tests that give accurate, actionable results for patient care. Specifically, RT-PCR and TMAs with microarrays have not been recommended by ASCO-CAP because they haven't been properly validated, and they are fraught with potential false negative results. So first and foremost, it's important to perform these tests in the laboratory according to ASCO-CAP guidelines, integrate them into the pathology report. Once this is accomplished, then we have a basis for discussion of the patient information typically at our breast cancer conferences. We also take into account any genomic expression profiles that are performed, whether it be Oncotype, MammaPrint, or Prosigna. These tests should follow pretty much the information that we have generated from traditional pathology and grading using the ASCO-CAP guidelines. So if there are any outliers in the gene expression profiling test for that, we typically discuss this at our tumor boards and try to drill down and find out why there are differences in these different modalities of testing. Gene expression profiling for ER-positive breast cancer should be used, we believe, in a setting in which tumors are of intermediate grade predominantly. Pathologists grade tumors very well, and they especially do very well with grading tumors that are grade 1 and that are grade 3. There tends to be more variation in the middle group, the intermediate grade tumors, so it's more likely that those tumors would benefit from further gene expression profiling. In a situation with very high-grade tumors in which there is some question as to the origin of the tumor, whether it be primary breast or not, I think that is in the realm of the pathologist. The pathologist has a variety of tools in their toolbox to assess whether these tumors are primary in the breast or metastatic to the breast. This is an area that is different from gene expression profiling, and gene expression profiling per se will probably add nothing in that situation other than tell you that it's a rapidly proliferating high-grade tumor. So in that situation, it really is within the realm of the pathologist's diagnosis to make that distinction, whether it's a primary breast tumor or a metastatic tumor to the breast.